Identification of psychosocial distress and referral. Athletic trainers in traditional settings interact with athletes on a daily basis following injury, but also before injuries ever occur. Athletic trainers also comfort athletes in the immediate aftermath of injury, offering initial emotional support and challenge, attentively listening to the concerns of the athlete, coaches, and parents, and discussing various treatment options. Athletic trainers are privy to a great deal of information given to them intentionally through athlete disclosure or unintentionally through observed conversations and interactions. Much of this information is part of the normal activities of athletes. However, on occasion, athletic trainers will hear or observe something that raises a red flag regarding an athlete's physical and or psychological health and well-being. In these cases, more formal counseling by experts with greater training may be required, and athletic trainers become the first line of defense in identifying issues of concern and the need for potential referrals. Creating a holistic sports medicine referral network. Athletic trainers often have many contacts within their environment, and having contacts that can help with different specializations of the athlete care that may include dermatology, neurology, cardiology, internal medicine, orthopedics, orthodontics and dentistry, optometry, and many other specializations. Unfortunately, mental health professionals are too frequently identified as a reaction to the conditions athletic trainers encounter with their athletes, rather than as a forethought before necessity arises. There are several problems with this approach. First, it may be difficult to locate, adequately screen, and identify ideal mental health professionals for referral networks when there is an issue of time urgency. Just as some physicians are more suitable as referral resources because of their expertise in sports medicine, their knowledge of the sport culture, or their willingness to expedite appointment scheduling for athletes, mental health professionals should be screened and evaluated on the same criteria in order to find ideal matches with the athletic trainer's care network. Secondly, when mental health professionals are identified in a reactive manner, it makes the referral to their care seem unnatural, as if this is odd or an unforeseen need in sports medicine, like we didn't plan ahead. To the contrary, mental health professionals should be presented to coaches and athletes as normal components of a holistic sports medicine referral network. Often, athletes perceive a stigma surrounding referral to mental health professionals. They may perceive referral to mental health professionals as indicative of weakness or mental instability. What's our scope of practice as an athletic trainer? There are several guiding documents from the Board of Certification Role Delineation Study, the BOC Standards of Professional Practice, the Athletic Training Education Competencies, and the NATA Code of Ethics. Competent care stipulates that athletic trainers, not having education and experience sufficient to the demands of a situation, are ethically bound to refer those athletes to other qualified members of a sports medicine team. Athletic trainers can rely upon three basic guiding principles to help them govern what falls within their scope of practice. First, do what you've been trained to do. Second, don't do what you have not been trained to do. And third, when in doubt, refer it out. When a referral network is needed, an athletic trainer must have an established and trusted referral network. This network should be built proactively and should identify individuals who have the training and expertise to help address different aspects of athlete health care, including medicine, nutrition, mental health, wellness, health promotion, and even legal counsel. Even when athletes perceive referral to mental health experts as useful, researchers have identified the following barriers to attaining psychological services. First, the high visibility of student athletes on campus. The high profile of many student athletes on campus make it difficult for them to enter counseling centers, especially those located on campus communities, without being recognized. To avoid being identified by others on campus, they may avoid going to those places. Second, time demands. Student athlete schedules are already a balancing act of academics, sports, and personal obligations. Adding counseling appointments to an already packed schedule is often difficult. Sometimes there are misconceptions about student athletes. Student athletes are often already viewed as a privileged group on campuses, with all their needs met by the athletic department. Counseling centers may not see the need to reach out to what is perceived as an already spoiled group. Restrictive environments. Athletic departments or coaches may see mental health professionals as outsiders and not trust the care or advice that could be provided. And student athlete attributes. Student athletes by nature are often self sufficient, self motivated, and independent. These are all traits that have made them successful in their sport performance. Because of the stigma often attached to using psychological services and the barriers that have been identified, it is important for athletic trainers to normalize the psychosocial referral network as just another part of the sports medicine team. Athletes may need to be convinced that just as they are ready to seek expert advice for physical difficulties such as an injury, seeking expert advice from mental health professionals regarding issues such as adjustment issues to injury, disordered eating, or even substance abuse is no different. In fact, seeking such advice is a sign of taking control of their situation and actively pursuing assistance for optimal care. As athletic trainers, we need to recognize the need for referral. We can do this by identifying signs and symptoms. We may collect these signs and symptoms through athlete self-reported data, direct observation of athletes' behaviors, or even indirect reports or observations of athletes from others, such as teammates or coaches. The 7 warning signs for behavioral health issues. 1. Unusual mood changes and increased difficulty controlling emotions. 2. Sleeping or eating significantly more or less than usual. 3. Excessive worry, anxiety, or sadness lasting more than a couple weeks. 4. Decreased performance at work, school, or even sport. 5. Noticeable decrease in concentration, problem-solving skills and memory. 6. Out of the ordinary social isolation from friends and family. In the case of athletes, this may also include teammates or coaches. And finally, 7. An increased use of alcohol or over-the-counter medication, or taking prescription drugs at doses higher than your physician recommends. Some different conditions that warrant referral. These include depression, anxiety, post-traumatic stress disorder, panic attack, disordered eating and eating disorders, and substance dependence and abuse. The American Psychiatric Association has the Diagnostic and Statistical Manual of Mental Health Disorders. This is the 5th edition, text revision. This is the most comprehensive, current, and critical resource for clinical practice available. This was released in March of 2022. This text provides a common language for clinicians involved in the diagnosis and the study of mental disorders and facilitates an objective assessment of symptom presentations across a variety of clinical settings, such as inpatient, outpatient, partially hospitalized, consultation liaison, clinical, private practice, and primary care settings. Depression, otherwise known as a major depressive disorder or clinical depression, is a common and serious mood disorder. Those who suffer from depression experience persistent feelings of sadness and hopelessness and lose interest in activities they once enjoyed. Aside from the emotional problems caused by depression, individuals can also present with physical symptoms such as chronic pain or digestive issues. To be diagnosed with depression, symptoms must be present for at least 2 weeks. The DSM-5 outlines the following criterion to make a diagnosis of depression. The individual must be experiencing 5 or more symptoms during the same 2-week period, and at least one of the symptoms should be either depressed mood or loss of interest or pleasure. The signs and symptoms of depression include depressed mood, decreased interest in pleasurable activities, weight loss or decreased appetite, insomnia or hypersomnia, psychomotor agitation, fatigue or loss of energy, feelings of worthlessness or guilt, cognitive disruptions, and suicidal ideation, suicidal planning, or even suicide attempt. To receive a diagnosis of depression, these symptoms must cause the individual clinically significant distress or impairment in social, occupational, or other important areas of function. The symptoms must also be separate from the result of substance abuse or other medical conditions. The APA offers a number of emerging measures for further research and clinical evaluation of depression. These patient assessment measures were developed to be administered at the initial patient interview and to monitor treatment progress. This is known as the PROMIS Emotional Distress Depression short form. This might be helpful to use in athletic training settings. We could use this during pre-participation physical examinations to identify individuals who might be at risk for depression. Anxiety. According to the American Psychiatric Association, anxiety is a normal response to stress and can even be beneficial in some situations, such as increasing attention and focus on a test or work task. By contrast, anxiety disorders differ from a temporary feeling of anxiousness or nervousness with more intense feelings of fear or anxiety. The DSM-5 specifically describes anxiety as an excessive worry and apprehensive expectation that occurs more days than not for at least 6 months about a number of events or activities, such as work or school performance. The anxiety and worry are associated with 3 or more of the following 6 symptoms, with at least some symptoms present more days than not for the past 6 months. These include restlessness or feeling keyed up or on edge, easily fatigued, difficulty concentrating or mind going blank, irritability, muscle tension, sleep disturbances such as difficulty falling or staying asleep, or restlessness and unsatisfied sleep. The anxiety, worry, or physical symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Anxiety disorders are the most common mental health concern in the United States, and it is estimated that more than 40 million adults, about 19% of the adult population, has an anxiety disorder. Approximately 7% of children aged 3 to 17 experience anxiety issues each year, and most people develop symptoms before the age of 21 years old. Women are more likely than men to have anxiety disorders, according to research. Post-traumatic stress disorder, also known as PTSD, is listed under the DSM-5 under trauma and stressor-related disorders, with conditions falling under the category dependent upon exposure to traumatic or stressful events as the diagnostic criterion. Previously, in the DSM-4, PTSD was classified as an anxiety disorder. PTSD involves difficulty recovering after experiencing or witnessing a traumatic event and can include both emotional and physical reactions. Traumatic or stressful events that may lead to PTSD include accidents, combat, forms of violence such as assault, and natural disasters. People who develop PTSD can have persistent, frightening thoughts and memories of the event or events, feelings of detachment or numbness, experience sleep problems, and be easily startled. Based on the data from the National Comorbidity Survey Replication Study in 2017, an estimated 3.6% of U.S. adults reported having PTSD in the year prior. Prevalence tends to be higher for women than men. Of the individuals with PTSD, an estimated 36% had serious impairments, 33% had moderate impairment, and 30% had a mild impairment. Impairments can include sleep disturbances, anxiety, recurrent memories of the trauma, hypersensitivity or hypervigilance, emotional detachment, and difficulty in everyday tasks, including work and socializing. For assessment, clinicians should consider a PTSD diagnosis if any of the below categories are present for more than 1 month and cause clinically significant distress or impairment in social, occupational, or other important areas of functions. These symptoms should not be attributed to the psychological effects of substances, such as medication or alcohol, or be explained by another medical condition. Those signs and symptoms include intense fear, helplessness or horror, persistent re-experiencing of the event, persistent avoidance of the associated stimuli, numbing of the general responsiveness, and persistent increased arousal. Panic disorders or panic attack. Panic disorder is characterized by episodic, unexplained panic attacks that occur without a clear trigger. Panic attacks are defined by the rapid onset of intense fear, typically peaking within about 10 minutes, with at least 4 of the physical and psychological symptoms in the DSM-5 diagnostic criteria. This may fall under the general category of anxiety and may also be associated with other mental disorders or general medical conditions. The signs and symptoms of panic attack are palpitations, pounding heart or accelerated heart rate, sweating, shaking, shortness of breath or feeling smothered, feelings of choking, chest pain or discomfort, nausea, dizziness, lightheadedness, or fainting, derealization or depersonalization, the fear of losing control or going crazy, fear of death, paresthesia, and even chills or hot flashes. Culture-specific symptoms such as tinnitus, neck soreness, headache, uncontrolled screaming or crying may also be seen. These symptoms should not be counted as one of the 4 required symptoms. In order to have a panic attack or panic disorder diagnosis, at least one of the attacks has been followed by 1 month or more of one or both of the following: either a persistent concern or worry about additional panic attacks or their consequences, or a significant maladaptive change in behavior related to the attacks. Eating disorders are serious but treatable mental and physical illnesses that can affect people of all genders, ages, races, religions, ethnicities, sexual orientations, body shapes, and weights. In the United States, 28.8 million Americans will suffer from an eating disorder at some point in their lives. A growing consensus suggests that it is a range of biological, psychological, and sociocultural factors. Disordered eating is characterized as unhealthy caloric restriction. It may include purging behaviors or even excessive exercise. 2 common eating disorders that we see within the athletic setting are anorexia nervosa and bulimia nervosa. Anorexia nervosa is an eating disorder characterized by weight loss or a lack of appropriate weight gain in growing children, difficulty maintaining an appropriate body weight for height, age, and stature, and in many individuals, a distortion of body image, also known as body dysmorphia. In female patients, we may also see the presence of what is called amenorrhea, or an absence of the menstrual cycle. For bulimia nervosa is characterized by a cycle of binge eating and a compensatory behavior such as self-induced vomiting, designed to undo or compensate for the effects of the binge eating. Bulimia nervosa typically occurs on average 2 to 3 times a week for at least 3 months. Many individuals suffering from bulimia nervosa focus intently on body shape and weight. Other disordered eating and eating disorders that may occur. Binge eating disorder is the most common eating disorder in the United States. It is characterized by recurrent episodes of eating large quantities of food, a feeling of loss of control during the binge, experiencing shame, distress, or guilt afterwards, and not regularly using unhealthy compensatory measures to counter the binge eating. Orthorexia was a term that was coined in 1998. This is used to describe an obsession with proper or healthful eating. Other specific feeding or eating disorders, or OSFED. OSFED is also known as eating disorder not otherwise specified in previous editions of the DSM. This was developed to encompass individuals who do not meet the strict criteria for anorexia or bulimia, but still have a significant eating disorder or disordered eating. Avoidant restrictive food intake disorder, or ARFID. ARFID is previously referred to as selective eating disorder. This involves limitations in the amount and/or types of food consumed, but does not involve any distress about body shape or size, or fears of fatness. Pica is an eating disorder that involves eating items that are not typically thought of as food and that do not contain any significant nutritional value, such as hair, dirt, and even paint chips. Remuneration disorder involves a regular regurgitation of food that occurs for at least 1 month. Regurgitated food may be rechewed, reswallowed, or spit out. Unspecified feeding or eating disorder applies to the presentation where symptoms characteristic of a feeding or eating disorder that cause clinically significant distress or impairment is prominent but do not meet the full criteria for any of the disorders in the feeding or eating disorder diagnostic class. Laxative abuse is serious and dangerous and involves the repeated and frequent use of laxatives to eliminate unwanted calories, lose weight, feel thin, or even feel empty. And compulsive exercise. This is extreme, excessive exercise that significantly interferes with the areas of one's life. Many people struggle with symptoms associated with this term. Substance dependence. According to the DSM-5, a substance use disorder involves patterns of symptoms caused by using a substance that an individual continues taking despite its negative effects. There are 11 criteria that can arise from substance misuse. These criteria fall under 4 basic categories: impaired control, physical dependence, social problems, and risky use. The 11 criteria are using more of a substance than intended or using it for longer than you're meant to, trying to cut down or stopping using the substance but being unable to do so, experiencing intense cravings or urges to use a substance, needing more of the substance to get the desired effect, also called tolerance, developing withdrawal symptoms when not using the substance, spending more time getting and using drugs and recovering from substance use, neglecting responsibilities at home, work, or school because of substance use, continuing to use even when it causes relationship problems, giving up important or desirable social and recreational activities due to substance use, using substances in risky settings that put you in danger, and continuing to use despite the substance causing problems to your physical and mental health. The signs and symptoms include one or more of the following within a 12-month time frame and does not meet the criteria for substance dependence. These are failure to uphold major obligations because of substance use, engagement in physically dangerous situations because of substance use, legal issues caused by substance use, and social issues caused by substance use. Once the athletic trainer recognizes the signs and symptoms of an athlete experiencing distress or of a mental health condition, the referral may take one of 2 forms. It may be either spontaneous or it may be planned. In a spontaneous referral, the situation is severe enough that it warrants immediate referral. For example, in an extreme case, the athlete may mention to the athletic trainer that they plan to do physical self-harm, referred to as non-suicidal self-injury. If the referral is planned, the athletic trainer should take several things into consideration: how to do it, when to do it, what to ask, what to look for, where to do it, and where to refer. This is all part of the referral process. Both the actual process of referral and to whom the athlete will be referred greatly depends upon the athlete and the situation, but the athletic trainer should have this planned before initiating the referral conversation. The timing of the referral will be based upon the following factors: the severity of the signs and symptoms, the coping resources of the athlete, the skills training of the athletic trainer, the relationship between the athlete and the athletic trainer, the relationship between the athletic trainer and the mental health professional, and the immediate situational and environmental factors. So how do we refer? A 5-phase process may include assessment, consultation, trial intervention, referral, and follow-up. In assessment, we use the athlete's signs and symptoms to determine the mental health needs. For the consultation, the athletic trainer contacts a mental health professional. The trial intervention. An athletic trainer should work with the athlete to assist them with coping and management strategies to decrease their distress. The referral. The athletic trainer initiates the referral process with the athlete. It is important to normalize the process during this stage. If the athlete agrees to the referral, the athletic trainer should help with the process of setting up an appointment. And similar to other referrals for physical conditions, may even accompany the athlete to the referral site. If the athlete does not agree to a referral, the athletic trainer should continue to monitor the athlete and initiate another trial intervention and referral at a later time. And finally, follow up. During the follow up phase, the athletic trainer communicates with the athlete and the mental health professional. In order to communicate with the mental health professional, we will need to obtain a waiver of confidentiality from the athlete. This communication may be as simple as the mental health professional reporting to the athletic trainer that the athlete has been seen for referral, or it may include suggested actions that the athletic trainer can take to further assist the athlete. Some psychosocial strategies that we can employ. These include social support, communication, and stress management techniques.